I'm Aghogho.
5 p.m. news update. It's time for the big hard fact. From now until 6, we're diving deep into one big issue, and there's no issue bigger than AIDS. Yesterday was World AIDS Day, but since it was on Sunday and we were not at work, we're carrying it over into today. That's how important World AIDS Day is. That's how important the fight against AIDS is.
Yeah, big fight. Ever since we came into the mainstream, it's been huge. The awareness, and we've gone from one fight to another. From the stigmatization, to all of that, and now it's the community we are focusing on as a theme for this year's discussion. And earlier in the year, we had the statistics rolled out, and estimates of a national HIV prevalence at 2.8. Well, there was a previous one, 2.8%, has been halved to 1.4%. But all of that, we're going to try and make sense of it with the discussions we're having this evening from two resource persons who've been in the field and help us to better understand HIV and AIDS.
Yes, indeed. Here's our big hard fact for today. According to the Nigeria HIV/AIDS Indicator and Impact Survey, the number of Nigerians living with HIV dropped by 40% last year to 1.9 million. So that's some encouraging news in this fight. We still have a long way to go, though. So, for example, transfers from mother to child during childbirth are still quite high. That's one area we need to tackle if we want to beat AIDS here in Nigeria. By the way, like Aghogho mentioned, the theme for this year's World AIDS Day is Community Makes the Difference. And today, let's spend time talking about the roles that communities play in fighting AIDS. And we mean communities of all types, not just, the village, or all kinds of communities. So let's take a look at the things that, as a nation, we've been doing right in our quest to eradicate HIV and AIDS. We'll also look at the things that we need to improve upon. We'll look at policy. We'll look at implementation. We'll also look at public awareness and the involvement of you and I in this battle. And as you hear from the experts, we hope that it's going to give you enough hard facts to form an informed opinion on this issue, and also for you to have a clear idea of the role that you can play. We have someone from the Initiative for Equal Rights on the show today. They are an NGO that continue to fight for the human rights of several Nigerians. Dr. Adebwite, thank you so much for joining us on Hard Facts.
Thank you very much, Sandra.
All right. And we also have Dr. Nkiru David, who is the Head Clinical Science Department, Nigeria Institute of Medical Research. Thank you very much for joining the conversation, Dr. David.
Thank you for inviting me. It's my pleasure.
And of course, you are our fourth guest. Throughout the show, we want to hear from you. We want to ask, for instance, when was the last time you got an HIV test? Do you believe that there's enough AIDS awareness in the society? What do you think that communities you belong to can do to help fight AIDS? So I'm talking about your village. I'm talking about the company that you work for. I'm talking about the neighborhood that you live in, your place of worship. Any place or group where you share a sense of ownership and unity with other people is a community. So what can those communities do? Now, I have to ask you, Dr. David, we have to start with the good news. The big news is, of course, that the percentage of Nigerians with HIV has reduced by 40% to 1.9 million. What are the factors behind this reduction? It's amazing.
Oh, well, a lot of work, has gone on since the federal government rollout of the HIV ART treatment program. In 2002, a lot of work has gone in. People that were positive got tested, started on treatment, and the good news is that the treatment does work. A lot of people that continued on their treatment the way they should, that they were adherent, became virally suppressed. Now, you must have heard of the expression U equals U. That U equals U means undetected, means untransmissible. So that when somebody that is HIV infected is on drugs and the viral load has dropped, so that when you test, you want to check the number of viruses in the person's body, it returns a count of undetected. That is below the level of detection of the machines we use. It's the probability of passing it on is much reduced. So that way, the transmission cycle has been reduced. And then again, pregnant women who are HIV positive and are on drugs, the probability of transmitting it to the unborn child is drastically reduced, so that we're no longer getting newborns infected with HIV. So all this, contributed to the drop in prevalence, I believe.
Do we have any things that she's left out, Dr. Adebite?
Yes, the initial estimate was like a kind of over-bloated estimate.
Okay.
So the surveys that were conducted, they were poorly conducted, but in the recent time we had an improved surveillance and the use of a better survey method, and they were actually they were able to arrive at a more accurate prevalence rate, and that's why we now have it like around that kind of 1.5%. So I think that is the major thing that contributes to having it lower than what we used to believe.
And I also know that earlier in the year there was a breakdown, Dr. Adegbite, a breakdown state by state that we can sort of look at regions where HIV and AIDS prevalence have made gains, so haven't made much improvement. When you look at the work we've done so far, how much money, even though I understand there's now a dearth in funding for HIV/AIDS, especially in Nigeria, in recent years, would you consider the 1.9% I see? Would you consider the reduction in prevalence rate now, so rather 1.4%, would you consider that as significant enough considering side-by-side resources we have thrown into this problem?
Yes, it's very significant, but I still want you to understand that the initial prevalence that we used to quote was wrong. And this is a more real prevalence. And when you are talking about prevalence, you are talking about those who are already having HIV infection. So you are not even talking of the rates of incidence, the new infections. You are talking of those who are already living with HIV. So what suddenly brought about reduction was such a sudden crash in the prevalence is because the new method that was employed to do survey is now more like is a better way, is a better method of doing it. So that's why we have that reduction. It's not that we actually have that reduction as if that people who have been having HIV, maybe they are dying, no. Maybe we are not more having new infections, no. We're having new infections every day. But what has suddenly crashed it is because they use a better survey method to find out the actual prevalence of HIV/AIDS in Nigeria.
All right, let's talk about viral load suppression, Dr. David. In 2016, 24% of all cases have suppressed viral loads. And by this year's survey, that percentage has almost doubled to slightly below 45%. That's almost half of all Nigerians living with HIV. So 2 questions in one that I have. What exactly is viral load suppression? And secondly, how were we able to double it in 2 years?
Okay, so a correction. It is not half of the people living with HIV that are virally suppressed.
Oh, okay.
It is half of those on treatment, you know.
Okay. It's
estimated that a large proportion are yet to know their status. So those that have been tested have been started on treatment. About 40-something% of them are suppressed.
Okay.
Now, I was talking about suppression before. Suppression means when you start, the way HIV comes into the body, when it gets into the body, usually the viral load goes high, okay? And then by the time the person starts drugs, the viral load comes down. When it comes down to the levels where we cannot detect it, to levels below 1,000 copies per ml of blood. So in 1 ml of blood, you have less than 1,000 viral copies. We say that person is suppressed. And as I said before, when the virus is suppressed, this is an immunosuppressive condition. If this virus is not suppressed and it attacks the immune system, then the person cannot, is not protected against opportunistic infections and all that. But when the viral load is suppressed, then the immune system recovers, and then the person can, is like any other person. So that's why viral suppression is so important. And like I said before, a lot more people are put on treatment. The drugs are better. I'm a pediatrician. So for us, earlier in the business of HIV, the drugs for kids were in syrup forms, they were in palatable forms, and so viral suppression amongst children was particularly low.
Okay.
But now that we have tablets, fix those combinations, drugs that can be taken just one tablet a day or 2 tablets a day, one in the morning, one in the evening. The adherence is better for patients to adhere to their treatment. It's better for them to keep to the treatment because the treatment modalities are better. They are more patient-friendly. So more people are adhering to their treatment, and so viral suppression is better.
So people don't have to take as many as, I know back dozens of tablets every single day. You're saying that is reduced now?
It's reduced now because there are fixed dose combinations. So if somebody is on 3 drugs, there are actually formulations that all the 3 drugs will be in one tablet. So it's easier for the patient to take.
All right.
And I think that has helped.
Dr. Adewite, what are your thoughts?
Yeah, you see, there is increased awareness about HIV infection now because of, I think, the campaign about it in the previous time. And that actually improved the uptake of HIV testing services. People go to know their status, even in the church, in the mosque, when people want to go for marriage, when they want to do wedding, they encourage them to know their status before they go into such binding agreements. And because of this, we see a lot of people, even when people want to go for surgeries, when people go for antenatal, when they rush people for emergencies, those are the things that the healthcare practitioners encourage people to do, to know their status. So in the process, they get to know their status, and then they go on treatment. At the moment we do test and start, that means that you don't need to wait till a particular period when your immune function or your level of immunity has dropped to a particular level. Now it's being observed and it's noted that the earlier people go on treatment, the better for them because it reduces the chance of developing complications from HIV. So now all this make people to start treatment on time. And when they start treatment on time, you see they fear some of the things that were keeping people away from treatment before. Some of them have been fading out, and a lot of people are on treatment now. And with a kind of more adherence counseling, people are able to adhere to their drugs. So when these drugs are in the system, they suppress the virus, and they now go into either the harm of virally suppressed or virally unsuppressed. But one of the things that is helping us in the viral suppression is that we have more drugs that are more potent, and they are more easily available, more accessible. We now have more sites where people can access treatment without having to go a far distance before they can access treatment. And one of the challenges that we initially had in the early phase of this epidemic was the sites were so few. So people had to travel from one state to another to go and access treatment.
That's right.
And somebody that is not economically buoyant, how do you expect that person to be keeping up to his or her appointment every time? So in the process of time, you discover that these people, they miss their appointments, they miss their drugs, and if they are missing their drugs, of course, there is no way the virus can become suppressed inside them. So now I've even heard of NGOs who are going from house to house, giving care to people, not only testing them, they are even giving them drugs in their houses, in their homes, so that they make life so easy for everybody.
Okay.
And in the process, you discover that people are now adhering to their drug, and then the virus inside them becomes suppressed. And again, another factor it is we now have the machine, the equipment for viral load testing more available in Nigeria than ever before.
I see.
So a lot of efforts have gone into it, bringing viral load testing machines, equipment, and all the things that are needed very close to people. And then we are able to monitor people well and adequately. Now, when you pick somebody who has high viral load, you want to allow that person to go into an enhanced adherence counseling. And in the process, you want to review the things that individual is doing wrong, that is making the viral load not to be suppressed in the first place. And you want to rule out everything that the patient may be contributing to it that is not making the patient to be having viral suppression. And then you want to counsel that individual. And then you give that individual a very short duration to come back. And then when the person comes back, you want to reassess that adherence. So how about what we discussed with you the last time? If somebody has been taking or indulging in alcohol, and you know that alcohol affects the potency of this drug, and then you counsel the person that, you have to stop the alcohol, which is affecting the drug that you are taking, and that is making it not to work effectively. And then when the person comes back, you want to reassess it, and you want to reinforce that adherence, and you want to also monitor with doing viral, or maybe like 2 monthly or every 3 months, until you get that person suppressed. That is now our target, because we now have a target. We want to make everybody to be suppressed, at least 95% of all the people who are on treatment. So because we now have a target, and everybody is running towards that target. I think those are some of it.
So those are some of the factors. Dr. David, while availability of the ARVs is something that we've improved on, it's still a limiting factor. So that means that if we want to see more viral load suppression in Nigeria, we need more ARVs getting into people's hands. So we've talked about people who are working to ensure that everybody gets it, those who are going door to door. The biggest obstacle to this has to be funding. Not enough money is being budgeted every year to buy enough ARVs for all Nigerians who are living with HIV. Now, this year's theme is communities make the difference. Are there not ways for the public to, add their own small contributions to funds to buy ARVs for people who need them? Is there, a crowdfunding, non-private sector element to this situation?
Okay, right. For now, I want to commend the other speaker, because counseling actually is key to good adherence, and then good adherence is key to viral suppression. So that is a very good point that he has made. Then, in terms of availability of drugs, for now, antiretroviral drugs are free from the national program. Because our international partners are helping us to get the drugs. For how long they will remain free, I cannot tell, but for now they are free. Now, free drugs, there are other logistic issues with accessing drugs. We've talked about the distance, people have to go. I know there's a large scale up of ARV treatment centers, and so there are a lot more centers than there used to be, but still there are people that are working and coming to, to a health facility may take them off work, and some of them, there are challenges with that. So right now there are a lot of issues with communities. We're talking about partnering with community pharmacies so that pharmacies right there in the community can dispense these antiretroviral drugs. So a patient goes to a health facility to get a prescription for, say, 3 months or for 6 months. And then the person can go to the pharmacy in the evening after work, and get their prescription filled. So that is already ongoing, and it's being scaled up in several states in the country. That, we hope, will ensure that a lot more people have access to the treatment program. Now, concerning how Nigerians can help, I know there are philanthropic Nigerians, but for the country, funding health service, that the proportion of the national budget that goes into health is still below the recommendations of the WHO.
That's right.
Now, there are many ways that the government can improve this funding. Everybody uses mobile phones. You can say that a proportion, just an insignificant proportion of the charge, of recharge cards should go into the health. There are so many ways that, the public can contribute to this beyond the traditional methods of taxation. And then, of course, there are public-spirited Nigerians that can come into the HIV program. We should not leave it only for bilateral funders, like Global Fund, USAID. I think that Nigerians should also get into the funding of the HIV program because international funding is dwindling every day. And they may dry up altogether one day. And if they do dry up, what is going to happen to is 1.9 million Nigerians. It's not a small number.
Yeah.
What is going to happen to all those Nigerians that will be needing drugs if there were nobody to buy the drugs for us? So I think the government needs to really sit up and talk, devise innovative ways to fund this program. The other person was saying that viral load should be done every 3 months. Actually, now in the national program, viral load, there is recommendation for once a year. Unless the person is failing, then when you increase counseling, you repeat viral load in 3 months. If you repeat it and it's still not okay, then you have to change the person's drugs. If the person were on first line, what we call first line drugs, you change to second line. But if the person were on second line drugs, third line drugs are a challenge. So we have to do everything to ensure that patients remain suppressed on first or at the most second line drugs so that they don't have, to fail second line treatment and need third line drugs, which are more expensive, not so easily accessible, and also have other problems. So that's
Let me talk to you about testing. Apart from ARVs, another major limiting factor is testing, Dr. David.
Yes.
Are there any estimates? I'm asking you because you're with the NIMR. Are there any estimates about how many Nigerians have gotten tested and how many have not?
Well, the estimates, it said that about 30% or thereabouts of infected persons do not know their status. And that's an estimate, of course.
Of course. Dr. Debite, what are the reasons why so many Nigerians have not gotten tested?
Sir, I was going to complete my thoughts.
Oh, okay. Sorry. Go ahead.
in NIMA right now, there is a study we're doing because, and I'm sure you've heard about key populations, and we think that the people that are not doing so well with HIV are adolescents and young people, because contrary to improvements in statistics about other population groups, adolescents and young people still have a lot more morbidity and mortality with HIV. And they are the ones that are not coming out to get tested. So the self-testing kit has just come into the country.
Okay.
And NIMA is actually at the forefront of doing innovative self-testing for adolescents and young people in Nigeria. Okay, so we're in the southern part of the country and we'll scale up to the north, where young people themselves are the drivers of making this self-test kit available to their peers.
I see.
Young people, so that they can get tested and then we can get to know their status. Because even if you scale up testing services in healthcare facilities, young people are not going to go there. If you do community outreaches and you just go, let's say to the town square and you make announcements, you want to do HIV testing, they should come out on a Saturday to get tested, I can assure you that young people will not come there. You understand? So we have to devise innovative ways where young people meet themselves and then they can be discussing at parties and stuff like that.
Maybe we could have a party, like a testing
Yes,
party.
at parties and stuff like that.
Exactly.
Yes. And then they get tested. And it's working. A lot more people are getting tested like that. And that is what we need to do to scale up this self-testing. Where you get a kit, you can go in the comfort of your home and get tested. And then the results will come and you will have numbers to call, to report that this is my result. And then you get adequate counseling and appropriate referral.
And these kits are in the public space, the kits?
Yes, they are.
Okay.
All right, let's talk about this some more. I'd like to get Dr. Debite's thoughts as well as to what he thinks the reasons are for why Nigerians are not getting tested. But I will come to that after the break. You're listening to Hard Facts. If you just joined us, welcome. Yesterday was World AIDS Day, and today we're having conversations about what communities can do, because this year the theme is Community Makes the Difference. And we have amazing guests on the show. From the Initiative for Equal Rights, Tears, we have Dr. Debite. And from NIMR for short, we have Dr. Nkiruka Davids. She's the head clinical science department for NIMR. And this conversation will continue in a bit. I am Sandra Ezekwesili.
And I'm Aghogho Oboh.
Hard Facts will be right back.
You are listening to Hard Facts with Sandra Ezekwesili and Aghogho Oboh.
Yes, indeed, Lagos. Yesterday was World AIDS Day. The theme this year, Community Makes the Difference. On the show with us are two resource persons, one of them with a non-governmental organization and the other one with a national organization. I'm talking about the head clinical science department from NIMA, Dr. Nkiru David, and a medical doctor from the Initiative for Equal Rights, TIERS, Dr. Adegbite Olatunde. Thank you so much for joining us on Hard Facts again.
Thank you.
Okay, so Dr. Adegbite, before the break, I wanted to find out what you thought the reasons were why so many Nigerians have not gotten tested.
Okay, on the part of people, I think it's because of fear. Fear is keeping people back from doing the HIV test. And the fear of stigma, and some people even consider being diagnosed with HIV. To them, it means death sentence.
Even in 2019? That's still happening in 2019?
Yes. It's just about last month, somebody, because she was diagnosed of HIV, she had to go and throw herself into the well, and she ended her life. So that is to tell you that people still fear HIV. People still consider the stigma. People still consider HIV infection as a death sentence. That is on the part of the people. But on the part of, let me say, policy now, before now, we were so generous with HIV testing. We were so indiscriminate about it. Everybody that was coming were doing testing for them. But at the moment, there is a kind of defined policy that, okay, now we are doing targeted testing. You have to assess the risk of an individual before you pick that person for test. You don't just want to do like an outreach now, and then you consume about 200 testing kits, and then you are identifying only 2 people. That's a waste of resources. So now we are doing a kind of targeted testing.
Okay.
We are focusing on people who you know that have high risk of getting infected with HIV, like the key population. Men who have sex with men, female sexual workers, people who inject drugs. So those are the people that we are considering to pick them for test. So there are some criteria now that even if anybody presents himself or herself in any healthcare facility that is doing HIV test free, they will screen that person to know if that person is eligible for testing or not. If that person is not eligible, that means you have to go somewhere where you are going to pay for HIV test for them to do it for you. So on the side of people, yes, it's fair. And then on the side of the people sponsoring this program, they want to limit the wastage, the resources that have been wasting, and they come up with different policies that, okay, we cannot do HIV tests for everybody again. You have to assess the risk of that individual. So I think that those are some of the things that contribute to people not knowing their status.
I see. Now let's talk about one of the key areas where Nigeria is struggling. Dr. David, transmission from mother to child, or TMTC. Earlier in the year, we got figures from UNAIDS that out of 160,000 babies born with HIV worldwide, 37,000 were in Nigeria. That's about 1 in 4. Why are we contributing to so many TMTC cases in the world? Why are we contributing so many?
Okay, just like it was saying, it still means that a lot of our women, young women, do not know their status before they get married. It means that people are pregnant and are not that HIV-infected women are pregnant and are not accessing antiretroviral treatments, which will make transmission to their babies much less if they're virally suppressed. But having said that, I want to say that we're coming from, a very high rate of mother-to-child transmission, and we have actually improved tremendously.
Okay.
But you know that Nigeria is a large country. In Africa, I think Nigeria makes up 1/4 of the population of, the continent. So when you hear numbers attributed to Nigeria, you must take it in context of the size of the country in terms of population.
Okay.
So we are not yet there, but we have come a long way from where we started. So what he was talking about just now, index partner testing and all that, it will go a long way, index partner testing, genealogy, to get the people that are most likely to be positive. And, before, the prevalence values we got were from like sentinel surveys amongst antenatal cases. It is still important that women know their status before they get pregnant. It is still important that if somebody has any reasons to think that they may be at risk, they should test. You understand? So that if we can get all HIV positive women on treatment even before they get pregnant and they become virally suppressed, or at the very least in pregnancy and they become virally suppressed, then the risk of transmission to their babies is much reduced.
I see. Now, I have to look at those numbers. I know you say that it's high because Nigeria and we plenty, but if you look deeper at those numbers, 4 out of pregnant women in the national survey claimed to have attended at least one antenatal appointment, but only 2 out of 5 of them said that they know their HIV status. How is that possible? How is it possible that half of the women who attend antenatals are not being tested for HIV, Dr. David?
They should be before now, but we have the opt-out strategy. In other words, you offer it to all pregnant women, but it's not compulsory. You understand?
I see.
Some people, out of fear, will decide not to do the test. Some people actually did the test, and they were told that it was positive, but they did not believe it. Because their spiritual leader told them that it was not true.
I see.
Or that it was not their portion. And so they did nothing about it. One of the most heartbreaking issues for me is when you see a mother who actually found out, by the time you dig deep, that at 3 months of gestation, that's of pregnancy, they actually had been told, and then they decided to go to a church or a mosque or somewhere, and they come back, to have a baby. When the baby is 6 months, 7 months, the baby is having symptoms suggestive, and then you test and the child is positive. It ought not to be like that any longer. We should not have any child born with HIV at the current level of treatment that is available. So some people, there is still this fear, this stigma, but HIV should no longer be a stigmatizing disease because it is amenable to treatment. And there are so many people highly placed who are positive, who are doing good things, and they are positive. It is just that they are accessing treatment and they are taking it as they should. So if people understand this, then the fear is removed.
Dr.
The stigma is not there.
Dr. Dewita, I want to hear your thoughts on this particular matter. Why is it possible that half of the women who attend antenatals are not being tested for HIV?
Well, just to also buttress on the point that you raised, that the high number of occurrence of HIV in the babies born in Nigeria. Well, we've been paraphrasing it, but the main thing is poverty and illiteracy.
Okay.
Those two things, they are very common around us. When a woman goes to deliver in a healthcare facility, and you will be spending like up to 40,000 naira for ordinary spontaneous vaginal delivery, as in for a woman to deliver herself without section, and in an environment, in a place where many people are unemployed, the fear will be there. So people, they don't have choice than to look for alternatives like traditional birth attendants and also attending faith-based clinics. And in some of these places, they are not doing HIV tests for them. Up to now, of course, there have been a lot of sensitizations and awareness about it, partnering with some of those traditional birth attendants and faith-based clinics. But it's still persistent in our environment. There are some women that patronize such places. They are not running HIV tests for them. And if they don't run HIV tests for a woman and she comes in labor, then you deliver. And there is nothing for you to do as intervention anymore because you don't know whether that woman is positive or not. So there is no way you can guide that person that, we found out that you are positive, so go and be assessing treatments in so and so place. So if they don't have the awareness of the status of the woman that they are attending to, there is no way they can link such an individual to treatment. So it's unfortunate and it's very common in our setting, and especially in the north. So illiteracy and poverty is driving the prevalence or the incidence of HIV positive cases among the newborns in Nigeria. So now, coming back to your question, please, can you state that question again?
I think you've answered it. I was asking, how is it possible that half of the women who attend antenatals are not being tested for HIV?
Exactly. So they deliver outside the healthcare facility.
I see.
So that's the main challenge.
I see.
All right, Dr. David, I know you say you are on some pilot work in the southern part of the country targeting for
adolescents and young people for HIV self-testing.
Exactly. Tell us how it's going. What is a typical day like in the field?
Okay, so it started last year. It started actually at the World AIDS Day last year, where we put out, it's like a crowdsourcing kind of thing. We put out a challenge for young people to come up with innovations on how to, scale up HIV self-testing among adolescents and young people. And a lot of them, brought up a lot of ideas. Out of those, about 15 of such groups were invited to a boot camp where they were taught about, the self-testing kit, how to go about, making it available to young people. And after all that, they were now sent to the field. So what happens, a lot of the young people, some of them are undergraduates or coppers. So they know where these young people gather, some of them at parties, some of them at, maybe in camp. And they talk to their peers and tell them that, okay, there is this a new way. Do you know your HIV status? That's where they start, after general conversations to break the ice. And then the person, depending on what they get, at the end of the day anyway, they're encouraged to get a self-testing kit. And then they take it home and then they do it. And then they do it and there are contacts for them to call.
Where can somebody buy these self-testing kits?
Right now, I know that Nigeria has, adopted it, but it's not yet universally available. So for now, it's not yet publicly available.
I see.
But now in the study, it's available. But I know that the country has adopted it. And very shortly, they will probably scale it up so that people can, get tested in the comfort, the privacy of their home.
I think if
now,
more people knew where they could get it and that they can get it on their own time, it could probably drive up testing.
Yes, I'm sure. It will, I am very certain that it will be scaled up and it will be available at pharmacies and maybe at vending machines and all that, but not yet. Now, the fear before now had been that, if people get tested at home, what if they turn out positive? What if they go and jump into the well or into the lagoon? But studies from other parts of the country, other parts of the world, have actually shown that is not a likely scenario. But to avert that, after the people do the test, there are numbers. We will ask them, do you want us to call you? Or if you don't want us to call you to find out, your results, you don't even have to tell us your results. You can call these numbers to get appropriate counseling so that if one is negative, the things you have been doing that, made you negative can be reinforced and you can continue therein. Or if one is positive, you can be linked immediately to care. And then you'll be counseled appropriately.
What are the ways we have... No, go ahead. I'll come back to my question.
Yes. So I was going to say that as at now, it's still a study. Even like yesterday, we were at Police College And the new set of young people pitched their ideas, about 30-something of them. Out of that, we'll select a few to go to a boot camp because we want to scale this up all over the nation. And then we are just doing it amongst adolescents and young people. But like the other colleague, my colleague said, the key populations are men having sex with men, injection drug users, female sex workers. So they too will benefit from this, getting tested in the comfort of their homes, so that the stigma, which is still a reality, though it ought not to be, the stigma and discrimination is reduced.
Dr. David as well as Dr. Adegbite, I'm sure when we look at the statistics, I'd like you both to contribute to this in the way that we look at the averages. It doesn't say the complete picture until we break it down into men and women. And then it suddenly becomes glaring that women are the ones taking the worst end of the stick, if it's mother to child or young women who are among the have the highest numbers in terms of new infections. In what ways is counseling being improved, especially for women who are living with HIV/AIDS or more likely to come up with that? Have we changed in any way the methods?
Okay, so women, especially young women, are particularly at risk because he talks about education and poverty. Some of these young women cannot negotiate safe sex. And you would have, I'm sure you know that a lot of young women are initiated into sex by older men. There are statistics to that effect. So a lot of them, they're not empowered with education. They're not empowered with, earning. They don't have enough earning power to say no to some of these men that want to take advantage of them. And that is why the female adolescent and the young woman is particularly at risk. And we have to ensure that education gets to these ones, that they are protected, and this is where in the government facilities we can only do so much because we're basically either research or healthcare service. But the non-governmental organizations that go into the communities should ensure the education of these young women and empower them with skills building, activities that can give them something to do. I was told about a place where there's fish for sex, so because people are hungry, somebody can offer them fish so that I can have sex with you. Such a person will not be able to say, oh, you have to use a condom, or I do not want, because they're hungry. So there's a lot of poverty in the land, there's a lot of ignorance, and we need to start tackling it from that point.
Do you think we need to do things as simple as encouraging women who are sexually active to go into a pharmacy and buy a condom? Because there's such a, I want to say stigma, but that's not the right word, for women who want to purchase contraceptives or condoms that men do not face when they go into a pharmacy to pick up a condom. So how do we break that? I don't know the right word for
that
it.
Word.
Yes.
Neither do I.
But how do we get to the point where it's okay for a woman who is sexually active to go into a pharmacy and pick up a condom?
It's a cultural thing, and cultural is dynamic, but it takes a long time for things to change. It will start with awareness. It will start with public enlightenment and education. And then it takes a bold person, to say that irrespective of what people say, because they will say it behind your back, you would buy it. So by the time a few bold people go by, it's just like living with HIV. At the beginning, people were not willing to come out and say, I'm HIV positive.
True.
Because of it. But now a lot more people are coming out. I run an adolescent clinic in Naima, and some of my adolescents say they want to be public. They want to tell that they have told their friends in university that they are positive. And the sky has not caved in. So, it takes one or two persons to be able to be at the vanguard of this and say that I will do this. But we need a lot of public enlightenment. Culture is changing, it's just that it's changing gradually. So women are expected to be more sexually circumspect. Than men. It's not something that is going to go away overnight, but gradually I believe that
we will dismantle that. I wonder what Dr. Adegbite thinks. Dr. Adegbite?
Yeah, one of the interventions that are available to reverse the picture that we are seeing in women and young women generally is that now we have female condom, which empowers females. You don't need to have the consent of your partner before you wear female condom. So unlike when you want to plead with your male partner to use male condom. And then that person may say, no, I don't enjoy it with condom. So, but you have the responsibility to protect yourself.
I see.
And female condom empowers you to do so.
Are female
If you
condoms widely available?
Well, it's available, but not widely.
Widely, okay.
Because people, even if you make it available free for people, and you demonstrate it to people how to use it, people are not using it. People are not using it.
Why?
They say it's very clumsy to wear, it's very difficult to wear. Oh, I would not want my partner to know that I'm wearing something. And female condom will not even interfere with sex. The man, if he doesn't see you wearing it, he may not even know that you are wearing anything. And he will still enjoy himself the way he's supposed to. So another intervention that is available is post-exposure prophylaxis and pre-exposure prophylaxis. Yes, post-exposure prophylaxis is there. If you suddenly get exposed, maybe during sex, and your partner is not wearing condom, and you don't know the HIV status of that individual, that's why post-exposure prophylaxis is available. But again, the problem is that if you go to some of our healthcare facilities, they will ask you, is it a consensual sex? Is it that, you want to know, is it a rape case or a consensual sex? If it is a consensual sex, they will say, hey, so you agree now. So why do you need to go on PEP? There are some facilities like that will discriminate that. So this is the consensual sex. No, we are not going to give you post-exposure prophylaxis. But pre-exposure prophylaxis is there. But it's not for everybody. It's only when you know that you are at risk of getting it. It's something that you need to be taking before you are exposed to it.
I see.
That's why they call it pre-exposure. Yes. So you need to be on that drug. You are already anticipating. You already know that you will be exposed. So you need to be on the drug. So those are some of the interventions that are available for women. And this, like pre-exposure prophylaxis, is more sellable to the female sexual workers. It's more sellable in the community of MSN, men who have sex with men. So, but you can't just preach it to, and it's more also sellable to women who know their HIV status of their partner to be positive, their husband to be positive.
Okay.
So it's more sellable to them. You can't just go into the midst of campus ladies and be preaching about pre-exposure prophylaxis. They won't accept it. The stigma of even seeing you with that drug will make anybody who sees you with it to believe that you have HIV, because they will not know which one is which. So stigma is one of the things that we make, that we affect the uptake of pre-exposure prophylaxis, even when it becomes available everywhere.
Okay.
People will still not want to go and assess it, because they will be thinking, if I am on this drug, or people see me with this drug, they will not believe that I don't have it,
HIV.
that I'm only trying to protect myself. But these interventions are there. They are available.
Okay. So I guess the big conversation that we will have on some other date is how to fight stigma. That's the